Chris Frederick from the Stretch to Win Institute in Chandler, Arizona, USA, and I'm overjoyed to have a relaxed but really focused conversation about postpartum conditions with Diane Lee from Vancouver, British Columbia, Canada. I'll introduce Diane first before she says hello. Diane has been a practicing physiotherapist for over 45 years and owns and directs her large practice with staff at Diane Lee and Associates, which is at dianelee.ca. She is a fellow of the Canadian Academy of Manipulative Therapy and is a pelvic floor and clinical specialist in women's health, among many other things. She is well published with contributing book chapters and journal articles, as well as being the author of highly regarded books, The Pelvic Girdle, which is right here. I have that. Can we get that in focus? Well, you take my word for it. And The Thorax, both published by Elsevier. Diane is the innovator of two pelvic support belts, for which she holds a patent for the compressor, COM-PRESSOR, compressor, and the baby belly pelvic support. And you can see that at babybellypelvicsupport.com. In June 2023, Diane received the Canadian Physiotherapy Professional Contribution Award. The purpose of this award is to recognize individuals who have enhanced the profession and the practice of physiotherapy through a unique, impactful, and outstanding contribution. Congratulations, Diane. Diane continues to mentor, teach, and evolve what she created called the Integrated Systems Model, or ISM. And in this webinar, you will be introduced to how it has successfully worked on patients of Diane and her staff for many years. And you will also learn how to get trained in this amazing system at the end of this webinar. Welcome, Diane.
Oh, thank you so much, Chris. Thanks for having me and for this wonderful idea. I'm happy to share the next hour with you and chat a little bit about how this regional interdependent approach can help us look at people with persistent problems after pregnancy.
Awesome. Well, if you are ready to go, let's start by having you please explain the ISM model, its evolution, how it applies to postpartum conditions such as persistent pelvic girdle pain with or without incontinence.
For sure. So the whole concept of this approach, which is a very functional biomechanical approach, as opposed to an approach which treats a local dysfunction. So I think in school, we learn how to treat the injured knee, the injured ankle, the acutely injured back. But unfortunately, there isn't enough time, or there just isn't enough bandwidth to teach the students how do we look at the relationship between impairments. And there's been a whole revolution in the last 10, 15 years that when these people with multiple impairments, when they have a story that kind of goes like this: when I was 14 years old, I had a really acute ankle injury, put it in a cast for 6 weeks, but there wasn't much rehab or anything else about it. And I got out of the cast and then I kept going. This is my story. When I was 16, I did a back handspring on the balance beam and I landed straddle. No treatment, but within a year, I started to develop urinary incontinence. Fast forward to the age of 29 and 33, I'd had 2 kids, never regained my continence after that, and started to have persistent groin and left-sided pelvic girdle pain. Okay, multiple treatments to my pelvis, nobody looking at my foot, nobody looking at the multiple head hits that I'd had in gymnastics at all, and went down this rabbit hole of local treatment, never getting any better. Meanwhile, I had pursued a career as physiotherapy, not trying to get better, just because I really wanted to help other people. It wasn't about me at all. But through the course of my training and in my really early years seeking a mentor, I started to work with some of the founding fathers of manual therapy in Canada, namely Cliff Fowler, John Oldham, and David Lamb. And it was in the late 70s, around about the time when iFOMP was starting to be developed. And I was fortunate enough to be able to be mentored by these guys who had trained with other individuals, physiotherapists and individuals outside of Canada, who had really encouraged them to think about their thinking and not just to follow rote protocols. And so in the early 80s, we got really tired of treating pain because we found that when we treated the low back, the person often would come back with a headache. Or if you treated somebody's ankle, they said, well, that feels good, but now my knee is sore. And we really couldn't predict, how do we know if we treat this area of the body that it's going to be the best place to treat? So it started with Earl Pettman developing this thing he called the quadrant courses. And so in 1986, I published an article on tennis elbow that was novel in that it looked at the neck and the relationship of the impaired mid-cervical spine to lateral elbow pain. And sure enough, now that's well known that the neck can produce referred pain into the arm and into the elbow, but in 1986, it wasn't. So we started to develop a way of looking at function, both through osteo and arthrokinematics, because it was all about the joint in the 80s. Manual therapy was all about the joint in the 1980s. And to look at if we could change alignment, if we could change the posture, if you like, of the hip, of the thorax, although we weren't really into the thorax then, that was the 90s. If we could change alignment, could we change function somewhere else? And we started to surprise ourselves. I can never forget, there was no internet then, Chris. There was no such thing as email or messenger, the multiple ways we communicate now. There was the telephone, and it was not the dial-up, but the punch the buttons telephone. So Cliff would be on the phone to Earl going, guess what? I manipulated a cuboid this morning and I made this guy's shoulder go through full elevation. Go figure that one out. We spent hours in the pub with many pints of beer, chatting about clinical cases and stories, until slowly over time, a method or a way of structuring an assessment that was highly based on a person's story, all of their traumas. Tell me everything that's happened to you, so I know everything. Earl coined this term he called EAP, exhausted adaptive potential, which happens to be his initials, by the way, Earl Allen Pettman. But anyway, he coined this term, and we started having this premise that, you know what, maybe we've been treating victims and not criminals for all these years. So Linda Joy Lee was a young physiotherapist who joined me at my clinic at the time when we were starting to pull all of this together. And I had just published the 3rd edition of the Pelvic Girdle book. And in that book, I had been traveling and teaching with Professor Andre Fleming. I'd met Paul Hodges at that time. We were getting into motor control and looking at the pelvic floor, transversus and multifidus in relationship to pelvic function. And Andre and I developed this model called the integrated model of function, which, and when we go into a deeper dive in looking at all of this, I'll take you through it intimately, the integrated model of function, which is a real special model, I think, looking at form closure, force closure, motor control, and our emotional state when the pelvis is what we call the driver. But what we started figuring out is that often the pelvis is the place where the symptoms are, particularly in the postpartum demographic. They have trauma to either the pelvic floor or the abdominal wall, and sometimes both. But they bring with it, most women bring with them into their pregnancy past histories of injury, either from sport or life or accidents or whatever. There's a rare woman who hasn't had something happen to them before they get pregnant. So now what happens with the pregnancy is they've now got increased load, changes in posture, changes in fascial tension, changes in joint function. And we can't just assume that post-delivery, the pelvic girdle pain that they have is only due to problems and issues in and around the pelvis, okay? So that may be where the persistent symptom lies. And maybe the symptom is pressure, maybe the symptom is incontinence, maybe it's groin pain or pain around the sacroiliac joint. But what we need is we really need to have a whole body, whole person approach. And I'm starting to dislike the term biopsychosocial even more and more as we lose what it really means. But it is the best term that we have in considering the whole person. But from the biomechanical perspective, I need to understand, how is that ankle sprain, that old ankle sprain, playing into what's happening through mid-stance of gait, which is happening to what the hip is doing, which requires the rotators of the hip to control what needs a highly functional pelvic floor in order to be able to manage. So if you have anywhere along that functional sling that's not working well, where the victim could be in the foot, the knee, or the pelvis. So we cannot use the location of pain anymore to guide where we treat for any condition that is weeks beyond the traumatic event. So as soon as we start seeing things that are 3-4 months on, if you're not working in a way or have a system where you can look at impairments in the foot and play them off what's happening in the pelvis, look at what's happening in the thorax and play all these different rings that are rotating in different directions and see, well, if I change this, what's the impact going to be on pelvic control or hip alignment? So what the integrated systems model does, and the name came from the 4th edition of the pelvic girdle book, the book that you held up, which was published in 2010, end of 2010, early 2011, when LJ and I, Linda Jolie and I were working quite closely together. And we coined this term, the integrated systems model, because we needed to have a way to identify that this approach, which is now could be called a regional interdependent model, a term coined by Josh Cleland, to be able to stand it apart from saying, this is how you treat the pelvis. No, this is how you treat the pelvis in relationship to impairments anywhere else in the body. And the 2018 book, The Thorax, which Handspring has published, goes into much deeper dive than just the thorax. It really is the integrated systems model and looking at it through the lens of the thorax and how many different things can impact function elsewhere in the body how many things can be impacted when you are treating the thorax. So number one, this isn't a model about treating pain. When people come to the clinic, I say to them, we don't treat pain here, we treat function. And as long as your pain can be phenotyped as either nociceptive or neuropathic, and it's not nociplastic, which is a central processing problem. If it's nociceptive, neuropathic, and you can identify for me what makes it better and makes it worse, then this approach that we use, which helps to restore function, will teach you how to manage your pain. So we never promise people that they'll be pain-free, but we can teach them how that they can understand it, what makes it better, what makes it worse, how they can get stronger, more mobile, and essentially more functional by finding the drivers of that pain, which are highly task-specific. So the model is very much based on working on a single task at a time, which is related to that person's functional goals. And then assessing the whole body to find out, which impairments are causing problems and which are reacting to problems. So which ones where are we going to treat and get our biggest bang for our buck, right? So there's lots of clinical reasoning. There's lots of manual assessment because it couldn't work in this approach without having trained hands. And it becomes art after a while. It becomes less protocol driven. There's no algorithm with it. It's the patient's story and your findings and your clinical reasoning of a cluster of findings that then leads you to the next test, to the next hypothesis, the next testing of that hypothesis. And it's the person's nervous system and their experience as you are changing various things that tells you whether you're on the right track or not. So we don't make any judgments in ISM. You can have a hypothesis. Gee, I think this twist between the thorax and the pelvis isn't good for this person's pelvic girdle. Maybe their SI joint is sore because they've got this rotation between the thorax and the pelvis. Well, rather than stopping there and then starting to treat joints and muscles and fascia and whatever we see to try to unwind that, we test the hypothesis first. So we manually take the twist out of the thorax. We find the driving rings that are rotating. And then we hold that corrected, which some people have challenged that word, but you hold it changed. And then you monitor the SI joint for changes in mobility and control. And if we can change something and improve performance or function of the pelvis, then I know that if I treat this remote area, I'm going to get a good outcome. But is that good outcome going to be something that the patient's nervous system perceives as being better? So we're always asking, how does this feel for you? Better, worse, no change. Is it easier for you to stand on your leg? Is it easier for you to squat? We're looking for the nervous system to go, wow, that feels good. Okay, let's go. Let's run with that. So it's a dance really between the two of us, figuring out what is the next steps and where do we go. So it's physiotherapy or physical therapy that no longer has an assessment at the beginning and then a whole bunch of treatment sessions after that. It's assess and treat, assess and treat, assess and treat, every single session, every single session.
There's so many questions I have. And, you know, it's like a cascade that you just started in my brain. That's all good stuff. But maybe just to reduce it to something more simple, and I'll look just to see if there's anyone asking questions. I see chat here. Let me just make sure. I'm going to look in the Q&As. No open questions. You know, you could, people are already making chat. So if you want to put the questions in the chat, I think that's all right to do that, or in the Q&A, it doesn't matter. But and my wife says Q&A, put it in the Q&A. Okay. Questions in the Q&A, please. Keep some control here. So is there any merit to the thinking of when you talk about drivers? Drivers could be anywhere in the body, right?
Yes, they can.
But because you have so many choices there, you basically going with the patient story, right? Their personal story, their personal history, put that all together. It's so individualized for them.
Yep.
But if we're talking about, you know, postpartum issues, yeah, there's history from the past in the ankle and anywhere. But would it be accurate to state that you still would at least start in the so-called core of the body, or the center of gravity of the body, the lumbopelvic girdle as the start, knowing that you may go down to the foot and ankle or up to the cranial, the atlas, or anywhere?
No.
Wow, good. I'm glad you said that. Because that's,
so for me,
we're taught, right, to kind of.
Yeah, exactly, because that's protocol driven. Now, let me reframe that and say the pelvis is the center of the universe for me in the body. And so I always check for pelvic control, because there is no such thing as a place of rest for the pelvis. You're either standing on it, sitting on it, or lying on it. So if you can't keep that pelvic ring integral, if you can't keep it compressed, something's going to start to hurt, right? So the first test I'll always do, regardless of the task, even if the task is head and neck rotation and sitting, they have to get from standing to sitting. Can they sit on a controlled platform? Can they sit with call it stable if you want. Can they sit with their form and force closure mechanisms intact? And we'll go into that more in the deeper dive. Yes, no, can they sit there? Because if they can't sit on a stable platform, it's going to change the motor control strategy all the way up the chain. If they're not sitting with the sacrum nutated relative to the two anonymous, the pelvic floor is going to overengage. That's going to pull the tailbone forward. That's going to send tension up the dura. And that may very well wake up old whiplash, old concussion, old dural type symptoms. So yes, I always want to make sure that the person can stand, sit, or walk with a stable pelvis. All right. Now, just if they can't, if we see poor control in one side, either the left or right SI joint or the pubic symphysis, it doesn't mean that I treat the pelvis to get control back. Because the driver, they may have had tons and tons of postpartum core training, pelvic floor, full pelvic floor assessment and treatment, their abdominal wall, lots of core training given to their abdominal wall. A lot of clinicians miss multifidus, but let's say they've had that as well. So let's say they've had lots of training, lots of alignment work done, but it doesn't stay. They keep coming. This is the person that comes back and says, my clinician told me my pelvis is twisted, or it's rotated, or I have an upslip, or I have a downslip. And they may very well have these things. But what is maintaining it and driving it is that old foot impairment that is now adding extra load is the tipping point, or the twist in the thorax, or something coming down from the cranium or from the neck. So I don't know what I have to do to restore pelvic control is my goal, getting it back if it's not there. So you're right there. Yes, I have to restore pelvic function first if it's not there. But how I restore pelvic function is going to be totally different for many postpartum women, because they all have different baggage, if you like, or impairments or things that they bring into the pregnancy with them. If you have a postpartum mom that has received treatment elsewhere and they have pelvic control, they have good pelvic control, and they are still getting pelvic girdle pain, then often this is the pelvis that's overcompressed. So you've got myofascial lines and things that are holding the sacrum nutated and not allowing it to move so that the pelvic can act like a shock absorber. So that's a different kettle of fish, right? So you may be looking for drivers for pelvic mobility and not drivers for pelvic control, okay? So the goal for me in certainly in postpartum moms is always to make sure that the first thing we've got back and healthy is pelvic control. But how I get that really depends, and that's where ISM really helps me to know where to go. But if it's a postpartum mom who is coming in with poor control but has no pelvic girdle pain, but they're complaining of plantar fasciitis or knee pain now when they're running, somebody who uses running for stress relief. Before my pregnancy, I always was running was how I felt good, how I relieved a lot of stress. And if they don't have pelvic control doesn't have to come with pain. So, I mean, loss of pelvic control doesn't have to be painful. You see lots of people who are not controlling their SI joint, but the victim is showing up somewhere else. So you can have a victim in the knee, or it can be a headache, or it could be the foot. And so the same scenario would apply. I would restore pelvic control before I went to the knee or the foot, even though the biomechanical fault that was causing the pain song was in the knee or the foot, right? And how I would know that is that if I unwound the pelvis, any twist in the pelvis, applied compression, force closure. So I became the motor control. I became the nervous system. I corrected the alignment. I compressed it together. And then I had them take a step forward. Their nervous system, hopefully, would say, that feels different. That feels different in a good way. All right, that's good enough. Let's start here. I would then treat the pelvis to ease the knee pain or the foot pain. Okay. And many times you'll find that there's more than one place in the body that you have to treat. So it's not about finding one spot that makes everything else perfect. It's about finding the one body region where you can start that gives you your biggest bang for buck according to what task you're working on. Because you can have different drivers for different tasks. Somebody who has pelvic girdle pain when they sit, for example, may have a totally different driver than that same person who says, yes, but I also have it when I walk or run. So even though we have a lot of evidence that has looked at the active straight leg raise in pelvic girdle pain patients, and we have evidence that's looked at the one leg standing, we have no evidence that has looked at pelvic control in a squat. But I wouldn't use the active straight leg raise test, nor would I use the one-legged standing test to assess for the person who had pelvic girdle pain in sitting, because strategies are individual and task specific. Tons of evidence for that. So I have to assess the strategy in the task that is problematic. Otherwise, all findings are irrelevant. And that's why I need the story. That's why I need the story.
I think that's a wonderful introduction, and beyond the introduction, creating the landscape for maybe some more specific conditions we can talk about, which was on the flyer that everyone saw. So if you're ready, would you like to move on to the next thing, which is
for sure,
what they call DRA? Now I don't know how you say it, diastasis or diastasis, depending on both. But let's say diastasis rectus abdominis, DRA, common persistent postpartum condition, right? And many women try so many different things to close the gap in their tummies. Why doesn't it close is a question that people have been asking. And maybe you can just define what a DRA is more specifically, and what it is, what it does, and what the issues are.
Big question. Every woman's abdominal wall stretches in pregnancy. 100% of women by 35, 36 weeks have widths between the rectus diastasis that are considered to be wider than normal, average nulliparous women. We know that. What we don't understand is why, for some, does that interrecti distance, or the gap between the recti in the linea album, why does that gap not come back to normal measures in some. And there have been many studies that have looked at risk factors for this. Why does it persist? And so far, there are no biomechanical risk factors that have been identified that are causal of this. So they're now starting to move into more looking at types of collagen, looking at nutrition, looking at gut health, looking at lots of different things, because we know that you can't tell somebody, you know, if you don't do sit-ups, if you don't do this or that, you won't get a DRA. Absolutely, we have no idea what causes it for some. You can see women who have triplets and their bellies look beautiful after, and you can see somebody who has, you know, a 6.5 pound single baby and her abdomen looks like it's been stretched to the moon and back, right? So
question, are you saying, did you just say, if I understood you correctly, there are no proven exercise that can prevent DRA?
Correct. No proven exercises, And the problem with all of this, Chris, is that we have just worked out, and it's not published yet, and when we say we, it's Paul Hodges and I, have just worked out that the interrecti distance is not a valid measure of severity or treatment outcome. It's more important to look at depth of the linea alba and distortion.
Oh.
So it's how lax is this connective tissue between the recti. It doesn't matter how wide it is. It matters how deep it is. The IRD is not a valid measure of severity, how severe it is. So you can see some women who are 7-8 centimeters wide, but they're only, you know, 0.5 centimeter deep. These women are going to do fine with an exercise program, a general exercise program that just trains the abdominal wall. And the thing is that people on Dr. Google, there are many people who sort of say, do my exercise program and this gap will close. They are not working with ultrasound, because when you work with ultrasound imaging, what you see is the gap doesn't close, it actually tenses. And when the gap gets bigger and tenses and comes apart, it feels like it's closed because you can't feel the edges of the rectus anymore. Yeah. And you put an ultrasound probe on it, and right away you kind of go, whoa, is this person is getting more connected, more, if all the abdominal muscles and in conjunction with or connection with the pelvic floor, multifidus, the diaphragm, the whole inner unit is working well, that interrecti distance initially gets wider. But as it gets wider, it gets less distorted, less doming, less sagging. So now we start to be able to load the connective tissue. And in every other connective tissue disorder, whether it's Achilles tendinopathy, rotator cuff disorders, gluteal tendinopathy, the evidence is clear. To modify the structure of connective tissue, you have to load it, right? You have to move it, to glide it, slide it, to hydrate it, and you have to load it. And you have to load it moderate to high with rest periods in between. So not too much, not too little, but Goldilocks and the three bears, just the right amount. So we set out, Paul and I set out to do a prospective trial, and it was interrupted by COVID. And we had 13 women who all had interrecti distances greater than 4 centimeters, right? So these weren't just the little ones. And I trained them hard. I trained these women hard, and I followed Robert Schleip's advice in terms of what does hard mean. Basically, we took these abdominal walls to the shake point. They were working hard, co-activating all of the abdominals when they could. So we built them up through the motor control strategy to be able to recruit all these muscles. And then we started working capacity. And we trained these women for some of them up to 3 years and some of them 1 year. There was no significant change beyond the 1 year mark. So up to 1 year postpartum, the connective tissue will do what it's going to do as part of natural healing. But after about a year or a year and a few months, there was no change in the interrecti distance. Now, these women got stronger. They were able to start to flatten their tummies, even ones with 7 and 8 centimeter separations. They were like super women, really strong and very functional. What changed was the distortion. So they were no longer they were no longer domed, they no longer sagged, they had lovely tension across the midline. And so with 3 years of strong exercises, the IRD did not change. And so we're seeing now in recent studies, Galuppe's group, Benjamin, there's a systematic review that's just published, and the conclusions are inaccurate because they're saying exercise training does not help DRA. Yes, it does. Exercise training does not help the IRD, but it helps the individual who has a diastasis because it gets less distorted. They get stronger. We're looking at the wrong measure. It is not a valid measure of severity. It is not a valid measure of progress, nor of outcome. And where ISM fits into this, because this is kind of what we're talking about here, is that LJ noticed this years ago. In 2004, she was talking to Paul about how the lower thoracic rings in the thorax, when you have rotations in those rings, which are incongruent to the direction of rotation of the pelvis. So basically your pelvis is rotating one way in the transverse plane, and your lower thorax is going the other. And it may be dominant, a priority ring in that part of the thorax, but we'll keep it simple for now. When that part of the thorax is rotated, very common to see that one transversus abdominis, particularly in the middle fibers of TA, middle and upper fibers of TA, don't come on as fast, as robust, as efficiently as they should. And when you take the twist out of the system, you see an immediate change in the recruitment of the transversus. And LJ always had this theory that there was something in relationship to the neural drive to the muscle that was in relationship to alignment. And we think about all the proprioceptors and mechanoreceptors in our joints and fascia and just tissue in general. It makes sense that the afferent input into the nervous system, if you change it, can lead to a different motor output. And she really wanted to test this in part of her PhD in, 20 years ago, but wasn't able to do it because we don't have intertester reliability for finding a ring that's rotated. We don't have confirmed biomechanics a la science for the biomechanics of the thoracic rings, because there isn't a machine on the planet that can yet measure intra-ring mobility, let alone inter-ring mobility. It's coming, it's very close. 20 years ago, it just wasn't there. Our hands can feel way more than machines can measure. And unfortunately, in a PhD study, that's going to stop you cold unless you can build on prior studies. But it doesn't negate the incredible clinical contribution to the field in that we test that now. So it doesn't work for everybody. There's a subgroup of women where you take the twists under the system and it doesn't change their motor control at all. Those people need specific cueing and training for TA or pelvic floor or multifidus, whatever it is. But there's a group of women, a group of people that when you take the twists under the system, the motor control normalizes itself or improves. And these are the people that do really well in Pilates and yoga and working with therapists who are really good at releasing and aligning and don't necessarily do much with training. If the system comes back on its own, that person will do fine. But then we have a subgroup of people who really need us. When you release an alignment, they feel worse. They fall apart because their nervous system doesn't switch strategies easily. So they've developed one strategy and one way of being able to navigate gravity on our planet. And you take that away from them, and now they feel worse. So they become fearful of the gym, of the studio, of exercise, right? And so they really need the physical therapy and the motor control training that is very muscle specific initially. And then they will start, and then we can build them up, and then they go from there.
So I have a question. So that is the old thing. You have to be careful about removing compensations that maybe that's the only thing that they're hanging on. And when you take that away, everything collapses, right? So you've just described just so many scenarios, and it just, for me, highlights, you really need to know almost a summary of what you said in the last half an hour since we started, because we're midway, just beyond the midway point here in the webinar. One must understand, at least as a physical therapist, as our profession, if not anyone working with women who are postpartum with these conditions, you really need to understand their story, have a very open mindset, and use a combination of, not only your grounding in science and evidence, but your intuition and your readiness to accept what feed you're getting right at that very moment. And you have to have all the skills, the capability of doing all these tests that you talk about that many of us just don't have. So we'll talk a little bit at the end about ISM and what it does. I think this is a nice way to just segue into that. Eventually, we're going to talk a little bit about ISM and what it can offer people towards the end of the webinar. At this point, we have some questions. One person said a little while ago, what do you mean by pelvic control? I think that's probably just in general. I think people may have different ideas about that.
Yeah, so I think the word stability has been overused. It means lots of different things. And so for a number of years now, we've stopped using stability because what is it? It's an engineering term that essentially means that when you perturb a system, if you push it, you provoke it, you push it, it can't come back to homeostasis. That's what stability is. So that's not really what we're talking about in the pelvic girdle. So in the pelvic girdle, we have three bones. You've got the sacrum and the two innominates. And from Andre's research in the 1990s, Andre Vleming, what we know is that when the sacrum, if this is the sacrum, this is the innominate, when a sacrum is flexed or nutated, so when it's, I hope nutation is a term everyone knows, it's the same as sacral flexion, it increases the tension in the main ligaments of the pelvis, sacrotuberous, sacrospinous, interosseous. And so when those ligaments become tense, it's like the closed pack position of any joint, in that you have maximum congruence, if you like, of the joint surfaces. The joint surfaces are compressed together. And so it resists any shearing or sliding of the joint surface. So the SI joint is not a planar joint once it's mature. It has a few ridges and grooves in it, kind of like a bicycle chain in a sprocket. And when we compress that in, now it's locked in, if you like. And Andre called this the self-locking mechanism, and it doesn't move much. But the ligaments can only tolerate so much load. The pelvis needs extra forces to provide that compression. The ligaments aren't enough. And that extra force comes from two systems of muscles. The deep system, which is your pelvic floor, sacral multifidus, and the lowest fibers of TA. And then the superficial system, which is your glutes and the oblique abdominals layered on top of it. Now, this is looking at the pelvis as a ring this way. Obviously, we've got long slings coming up from the adductors, from the legs, and these are all muscle systems that can assist those fascial slings in applying compression. But the first thing that has to be there is what Carolyn Richardson and her group had called that inner unit of muscles, right? That's the force closure mechanism. So if the form and force closure mechanisms are not working well, what happens is that the sacrum doesn't stay nutated relative to the innominate. It counternutates. Now, for those of you who are familiar with an osteopathic model, what happens when we walk in normal gait is that the sacrum goes into a left on left and then a right on right. Okay? Forward torsion one way, forward torsion the other way. It nutates more on one side. It doesn't come out of nutation on the other, comes back to neutral bit, but it never counternutates. If it counternutates on that side, in osteopathy, they would call that a right on left or a left on right, a backward sacral torsion. So we have this old positional language now that's brought forward into 2023, where we talk about, okay, the sacrum that remains nutated throughout a task is self-locked. It's controlled, it's stable, it's form and force closure mechanisms that are driven by motor control, the nervous system, are integral, intact. Now, it doesn't stay there forever. It can't. That would hurt. It's got to come out of it a little bit, right? The SI joint that can't do that, so that the sacrum that counternutates, or the innominate that relatively anteriorly rotates relative to that side of the sacrum, the tension in the form closure mechanism, all those ligaments, is slightly less. And Barb Hungerford ended up calling that the unlocked SI joint. So Andre called it self-locked. It's a set like a keystone in a wedge. It's a self-locking mechanism. And when it's not doing that, Barb started calling it unlocked. So here now we had this term, if you've got an unlocking SI joint, blah, blah, blah. Well, we don't talk about unlocking knees and we don't talk about unlocking ankles. We talk about the poorly controlled knee, the knee that cannot maintain its alignment over the foot, where maybe the AP slide of the tibia and the femur isn't well controlled because of an ACL injury. So control has become the word that we've used when we're talking about if you are palpating the sacrum with one hand and you're inanimate with the other, not the PSIS and S2. There's 12 intertester reliability studies that tell us we're useless at that. So to be evidence informed, we don't do what they tell us we're useless at. We do something that they haven't studied yet, because then you can be evidence-based. All right. Now, it is much better when you stay further away from the axis. So one hand on the sacrum, other hand on the inanimate. You should literally feel nothing within that pelvis when they squat, when they stand on one leg, because the sacroiliac joint only has between 4 and 6 degrees of movement. It's a small movement. And yes, we can feel that small movement, but it shouldn't be happening whenever you are in weight bearing. So whenever we're in closed chain, that SI joint, which is loaded, should be sacrum nutated, inanimate, posteriorly rotated. So when I talk about an SI joint that is losing control, what you feel happening is that as you increase the load on the joint, you feel the inanimate anteriorly rotate relative to the sacrum. Okay. And people often starting with this test will say, whoa, that's subtle. And it's only subtle if you don't have a brain map for it. But as a clinician, as you start to build an inventory of feeling more and more SI joints that don't have control, you start to be able to not only feel it, you can see when it starts to happen, when somebody else's hands are on it. And it literally, Chris, when we do this in the series, it takes 1 week to get good at this. 1 week.
That's not a lot of time. I thought it would take a lot longer.
No, 1 week, 5 days. By the end of the first part, everybody's picking up SI joints, and the intertester reliability is really, really, really good. And when it's not good, it's often because of the tester and some problems that we have to sort in them with respect to what's going on between the cranium and the upper thorax in terms of what they see and feel. But yeah, and we sort all that. We sort all that out as well. Yeah.
We need to really get, all of us really need to get good at that. And I'm so happy that you're teaching it, and we'll talk about that a little bit more at the end.
Yeah, we will. And we have good evidence for it now too. There's Barb Hungerford's done the intertester reliability study on it. And so it's there. It's there. We have the evidence.
I have a question from Stephen Harold. Thanks, Steve. That last question was from Lara Jimenez. Hopefully that answered your question, Lara. For me, it certainly did. That was an elegant answer. So for Stephen, with the abdominal training you performed in your study for the women postpartum, were breathing techniques trained along with the exercises? I've noticed even in individuals not postpartum, when abdominal function is reduced, breathing mechanics are also usually faulty.
Absolutely. Absolutely. So breathing is always integrated in with all of the exercises, because we're not just training the abdominal wall. We're training pelvic floor, breathing, the diaphragm, we're treating the whole unit. So absolutely. Absolutely we're treating the, we're using breathing. Breathing is integrated in with all of the exercises, no breath holding allowed. And some women prefer or are better when they exert on the inhale breath. I'm one of them. And others when they exert on the exhale. And I haven't quite figured that out yet as to why. And I don't have to, because I can test them, right? I can test how strong they are when they inhale hold or when they exhale hold. So you can test which strategy of using the breath when they engage that deep system is more effective for them. Right.
We've all developed differently. We've all developed our own ways, and we have to take that into account, be open-minded and test. One more question here. I'm 19 from Carla Randall. Hello, Carla. I'm 19 months postpartum. I strength train 6 days a week. I have PSIS pain, and I feel like I get inflammation in my pelvis when I do deep core training. I don't know where to start to get help. Where do I start?
This is a classic example, Carla, of where your pelvis is the victim of something else. So if you have been training this hard, you should be better, right? And you know you should be better. So I would be curious to know, number one, do you have pelvic control? I bet you don't. because there's a ligament that comes right off the bottom of the PSIS called the long dorsal sacroiliac ligament. And Frank Willard had figured out, and together with Andre, that this ligament comes under tension when the sacrum is counternutated. So if you palpate right under the PSIS, right under that point, and you push there and it's tender, chances are that ligament is under tension, which tells me that you're loading with the sacrum in counternutation. I can't tell you why. I can only tell you that your pelvis is probably the victim of something else. It may be something coming down from the thorax. It may be something coming up from below. But you need an assessment, no more assessment of your pelvis. You need a whole body biomechanical assessment to see what do we have to do to bring back pelvic control.
Well, besides flying out to Vancouver to your clinic, do you have a directory of people certified by you in your system where they can go to your website?
Yep. Okay. So if they go to the Learn website under Find a Practitioner, and anybody who has done the series since 2007 with LJ and I, and anybody who after 2013 has done it with me, will be listed there.
What is that website again?
It's just www.learnwithdianelee.com.
Okay, great. Thank you. All right. I think we have time still for the last condition. Many clinicians and clients note that pregnancy impacts their posture, and many healthcare practitioners feel that posture must be, quote, fixed, yet the current evidence contradicts this. How does ISM, your model, determine when posture plays a role in persistent conditions following pregnancy, such as pelvic organ prolapse? And I have a person who asked a question, does prolapse get better or go away, or is it something that comes and goes? So
oh man, Lynn, that's a big question. So let me talk about this, the first bit first. So there's a real trend in physiotherapy, and a lot of the research has come from your neck of the woods and where you wanted to train, Chris. A lot of this research has come from Curtin, from Peter Sullivan's group, where people are beginning to think that posture doesn't matter. It doesn't matter how you lift, doesn't matter how you sit. And there's been studies that have been done that have looked at whether or not a certain posture causes pain. Well, we know from the pain neuroscience that there's no pathology in persistent conditions that always correlates to pain. So developing a research study that sort of says, if you sit with your head forward like this, is it going to hurt? And I can sit with my head forward like this and tell you, no, this doesn't hurt. But if I was to sit there in that position for a long period of time, would it begin to provoke symptoms is the next question. And you know what? We don't have to have the answer to that, because for some people, it's not going to, and for others, it is. So this is a situation where we look at somebody, and let's say we see a postpartum mom who is now standing here. Your common anterior pelvic sway, posterior tilt, drop the thorax down, and they hold babe here, or they hold babe here off to one side. Should we change that in every life? And the answer is, I don't know. Let's test it. So it's very simple to just bring their pelvis back over their feet, stack the pelvis up over their feet, unwind any transverse plane rotation, lengthen, unwind them, and then ask them, better, worse, no change. How does it feel in your body when you do this? So instead of me making the judgment and saying, you shouldn't do that, I'm going to ask your nervous system to answer the question for me. What does it feel like when you do this? And it's amazing how many times you can do the simplest of things. You can say to somebody, look, all I want you to do is just where do you feel the weight going through your feet? And someone with an anterior pelvic sway will often say, I feel it in my forefoot or my toes. Say, look, bring your pelvis back so you feel your weight is on the heels. And now just lengthen up here and then just soften in the sternum. Where do you feel the weight in your feet now? Feel it in my heels. And how much weight do you feel? They say, oh, I feel lighter. Okay, this is all I want you to practice. And it may seem simple, but trust me, it's not. It's not. Because the moment you stop thinking about it, gravity's going to win and you're going to go back. So this really takes a lot of attention and awareness during the day. But that's all I want to change. And I want to see which of your symptoms are in relationship to this posture in the first place, because that's going to answer whether we need to release this muscle or this joint, or actually get in there and do some manual things to help you be able to maintain that. Now, the beauty of not opening up their body, releasing things, and making it easier for them to get there first is that if they now then get a sense of the value of them doing the work. Because if you make it easy for them, not only does there start to become a codependency where they think, okay, you fixed me, you release this and you made me feel better. But they lose the wowness of when they come back, you're going, do you know how many times a day I stand like that? And my answer always is, no, I don't, but now you do. And if you've changed that, what's happened with your symptoms? And if there's no change in symptoms, then you're going down the wrong path, right? But if and it doesn't have to be a total alleviation of pain, it can be just that I don't feel as much pressure in my pelvic floor, right? So this is where we start getting into the whole pressure conversation of prolapse. So if somebody's prolapse is secondary to pressure, then having a sway back or a collapsed posture that increases pressure is definitely going to be relevant. And the other tool that we introduce in the series and teach a little bit, but not totally, is the use of real-time ultrasound imaging. And so some of the smaller units now, like the Clarius or the Butterfly IQ, some of the handhelds that they don't use in hospitals, they don't cost $250,000 or even $50,000, but small, they're like $5,000 to $7,000. Are incredibly useful for being able to show people, look what happens to your pelvic organ support. So with transperineal ultrasound, so the probe is on the perineum, but it's not up any opening. It's external, but it's on the perineum. They can watch in real time and see if I change your foot, if I correct your thorax, if I change posture. Watch what happens now when you contract and relax your pelvic floor. They can totally see the change in the support of the pelvic organs. And we do this for both men, post-prostate surgery, and also for women after pregnancy. And when the prolapse is in relationship to pressure, and not because of a puborectalis avulsion or a massive increase in size of the levator hiatus that is a structural thing that we can't change, we see massive changes in people's symptoms with prolapse, particularly when we combine them with hypopressives, which is a form of breathing, which is an apneic breath, very old, very ancient breathing pattern from yoga that's become popular again, and teaching people how to not descend the diaphragm so much on the inhale breath, how to keep the diaphragm up in the thorax and to use a lateral costal expansion breath so there isn't so much downward pressure. This can really, really help mitigate or manage the pressure. So by using patient feedback in terms of how it feels and real-time ultrasound imaging, we don't need to judge a posture anymore. We can test it for individuals and determine for whom would it be good to go down this pathway and for whom is it not good, or is it not going to change anything. So the whole premise of ISM, it can be just as simple as putting in a heel lift, or as simple as bring your pelvis back over your feet, right? It's changing something, and then using a very scientific method of testing your hypothesis. So you go from this whole cluster of findings, I think this, then test it. If you're on the right track, the person's nervous system should tell you either by increased range of motion, decreased effort to move, or a reduction in symptom that you're on the right track. If the pain song is nociceptive or neuropathic, or if the symptom that you have is not a central processing problem. So if you have an upregulated nervous system because of unresolved trauma, and the trauma could be biopsychosocial, could be biomechanical, psychological, social, relationship, it can be all sorts of that. And if it's unresolved and you are in a state of an upregulated sympathetic nervous system, changing the cranium, changing a ring, compressing the pelvis, stacking a talus will do nothing. The driver in this situation is the trauma and the impact of the trauma on the neurovascular system. So we're seeing a lot of vascular issues with with the dura, because of Batson's plexus, all the venous sinuses in the cranium that are in relationship to the arterial system that's being driven by the sympathetic nervous system to get ready for fight or flight. So in that situation, the story again becomes really, really relevant in the sense that you have the person who can't always identify a task that makes him better or worse. Everything hurts. Nothing makes it feel better. Everything feels better for a bit, and then I feel worse again. This is the person who most physical therapists listen to the story and go, where do I start? Throw your hands up in the air. And as soon as you start to delve into the trauma world and you understand more about the sympathetic nervous system and its impact on the arterial system and thus the venous system, the pathway forward from that then becomes clear. So then for sure it becomes your craniodural work, breathing techniques, meditation, stress relieving techniques, nature, happy place, this kind of thing, and less about, I'm going to mobilize the 6th costotransverse joint so that this ring can rotate. Although, as Bessel van der Kolk will say, he never starts talk therapy, psychotalk therapy first with any trauma patient. He always opens the rib cage, because unless you can breathe and open the rib cage, you can't calm yourself down.
Oh,
so how if you've got somebody with multiple ring rotations and things like that? Yeah, we can use our manual tools and techniques. Open up the rib cage with the goal of, I need you to be able to breathe in a way that gets your ventral vagal nerve on board, that gets your parasympathetic, that starts to calm things down, because we know how valuable a good walk by the ocean or in nature or a ride on your bike is. But we have to get you back to that point.
Oh my God, all the people with long COVID are not being touched in a way that can enable them to get past all that trauma, psychologically as well as physically. Diane, that was amazing. And I'm just going to say right now to everyone, we are going to take a deep dive, because selfishly, I want to take a deeper dive than we have been during this just an hour. So we already have arranged, I have arranged for Diane, and she so graciously accepts to do 3 2-hour seminars starting September 13th this year. So we'll send you an email, full description and registration. You'll get it this week. We will attempt to answer some questions we can't answer now because we're coming at the top of the hour. Well, hopefully I can maybe get some answers more from Diane. We'll talk about that later, so if I can send them to you. But other than that, Diane, just in the last minutes that we have, can you please briefly describe what they can get from getting trained in the integrated systems model that you teach? I have to tell you, everyone, I'm inviting you to come with me. I'm going there. In January 2024, she has offline preparation and then live training with Diane Lee personally before she retires. You've got to get trained by her. That's why I'm going. So,
it's going to be a really fun course having you with us, Chris. And I really believe in a lot of peer learning. So one of the beauties of the series is a 6-month mentorship program, but we get together 3 times in that 6 months for in-person stuff. Because you cannot interpret a finding you can't find. I need you to help you find these findings so that we can have the skills to develop the clinical reasoning, okay? So and then we set up a private chat forum where clinical cases are uploaded every week. So there's tons and tons of case story sharing. This is very much a case story driven course. But it is also highly evidence informed. So the reference list and the evidence that we draw on it's extensive. And as Chris mentioned, it's there's a lot of online videos. There's over 440 5-minute videos that support you, and you have access to that stuff for as long as I'm teaching. And I don't have any plans on retiring. So the website where you can learn more about the series is www.learnwithdianelee.com. And we are going to be diving more deeply into all 3 of these topics we've discussed tonight. I'll have PowerPoint presentations to share with you guys. We'll go into all of these theories a little bit more. And if you're interested in joining Chris and coming to the Great White North, it's more the Great Wet North in Vancouver in January. What you get out of doing this, and what I'm told from multiple practitioners who do it, is we make physical therapy fun again. we give you permission to play, permission to test, to try, and to integrate your models. So if you feel highly skilled in whatever method or model that you're doing, whether it's the Institute of Physical Art, whether it's Jean-Pierre Barral's work, ISM will integrate with that quite well. And you will become a better version of you. I don't want anybody, and nobody will become a clone of me or a clone of Chris. But by learning together and sharing and continuing to learn together, we become better versions of ourselves. And I really think that this is just plain good old physical therapy and bringing the clinical expertise back into evidence-based practice.
Diane, thank you so much. I am
Thank you.
really, I'm about to cry because I really feel so good about this.
We had a lot of fun.
Yes, we did. Thank you so much. I look forward to more fun coming up. And again, guys, we will email you the details about the upcoming webinars that will be starting on September 13th. Meantime, have a wonderful evening.
Can I just address one more thing?
Oh, yeah, please do.
The series is not just for physiotherapists. It is for, but therapists, you can email me directly and send me your resume or your course list. If you have skills in manual therapy and you have skills in exercise training, this course is for you. All right. You struggle if you're just an exercise practitioner. You struggle if you're just a massage therapist. But if you have skills that can release and move people, then come join us.
I love it. We need more healers.
Yeah, we do.
We
do.
Thank you so much, Diane. Until we meet again, everyone have a wonderful evening. Good night.
Thank you.